Welcome to This Week in Health IT, where we discuss the news, information, and emerging thought with leaders from across the healthcare industry. This is episode number 17. It's Friday, May 4th. Today, we used the VA as a canvas for painting what a health system might accomplish with the right platforms. This podcast is brought to you by Health Lyrics. Is your health system positioned to ride the wave of change? We've delivered agile, efficient, and cost-effective IT for healthcare. Get ahead of the wave. Visit healthlyrics.com to schedule your free consultation. My name is Bill Russell, recovering healthcare CIO, writer, and consultant with the previously mentioned Health Lyrics. I'm always asking people, who they would like for me to have on the show, who's interesting, who's doing fun things. And today's guest is actually the name which comes up the most. I had dinner with some of his compatriots last week in Arizona, and they told me not to tell him that. But it's just flat out true. People say, we want to hear from Dale Sanders. So today I'm joined by Dale Sanders, President of Technology for Health Catalyst. Dale, welcome to the show.
Thanks, Bill. That's terrible pressure, by the way, friend. Now, I don't know how I'd live up to that.
Yeah, it's funny. I was having dinner with a couple of people at the Scottsdale Institute last week, and it turns out they were from Health Catalyst. We were talking about some things, and I said, "Well, Dale's going to be on the show, and he's one of the most requested." They said, "Oh, please don't tell him that."
Yeah, right. That probably came from Jeff Grandy, I'm thinking.
Yeah, it was. Let me give a little bit of your bio. It's really fascinating. So let's see. So Intermountain Healthcare from 1997 to 2005, where you were the chief architect for Enterprise Data Warehouse, which was a pretty big deal because at the time I think Intermountain had their own EHR platform and really was building things up from the ground up.
Yeah.
You founded Healthcare Data Warehousing Association from 2005 to 2009, CIO for Northwestern University Physicians Group, and chief architect for Northwestern Medical EDW. From 2009 to 12, you served as a CIO for the National Health System of the Cayman Islands. Did you live in the Cayman Islands?
Yeah, I did.
Wow, what was that like?
It was life-changing. I mean, of course, it's beautiful for all the reasons that we all would appreciate, right? Just fantastic people and culture, and I lived on the beach, and I swim every morning, and but what was really cool is it's a national health system, in an economy that doesn't have personal income tax or corporate income tax.
Wow.
Yeah, they provide guaranteed care for everybody in the population, and there's also a private market there. So it was like this little health ecosystem in a laboratory, and I got to work on everything from national policy with the Minister of Health and the Premier down to configuring web browsers for physicians. So it was just great.
So the obvious question is, why did you come back? Why it is an island. I mean, it's pretty remote. So is that the reason you came back, to do something else?
Well, my mom was in the later years of her life, and I just thought to myself, I want to spend time with her while she's still healthy.
Yeah.
So I put a hold on my career and moved back to my hometown in Durango, Colorado, and spent time with her. And as it turned out, it was awesome because she was in great health. And 2 years after I moved back, she passed away in her sleep in her home that she'd lived in for 60 years. So it was the best decision ever to move from the Cayman Islands, even though it was a little hard too.
Yeah, and I've heard that story now. I mean, this is a tangent, but I've heard that story now from a handful of people that put their made career decisions based on caring for their parents and in those latter years, and not a single one have I talked to yet that has regretted that decision. And you're just another one on that list. So
yeah, I can't imagine. It just was wonderful, and I encourage it. It's not everybody can do it, obviously, but here's just one last comment on this. I really didn't know how I was going to make a living when I did that. I just cut the cord and said, I'm going to figure it out. If I have to, 10 bar and drive a forklift, I will do that to spend time with her. And as it turned out, that's about the same time that Health Catalyst kind of got spun up. But I had no clue that was going to happen at that time. So, yeah.
things have a way of working out. And then
That's right.
the last piece of information, which is relevant for today's conversation, CIO on Looking Glass Airborne Command Post in the U.S. Air Force, IT support for the Reagan-Gorbachev summits, which you have so many stories I'd love to go off on, but we have to get to the show here. So nuclear threat assessment for the National Security Agency and START Treaty, chief architect for Intel Corp's Integrated Logistics Data Warehouse and co-founder of Information Technology International, and obviously president for Health Catalyst. One of the things we like to do is to ask each of our co-hosts to give us an idea of what they're currently working on or what they're excited about.
Well, it's Health Catalyst centric right now for sure. In the last 2 years, we've basically rebuilt the technology at Health Catalyst. For the most part, almost bulldozed everything we were doing prior to 2 years ago to the ground and started over. So this thing that we now call the data operating system, which may sound like a bit of a buzz phrase, but the term is genuine and it's purposely intended to convey something different about analytics and workflow application development. So we're having a lot of fun with that, and we're building applications on top of the data operating system. And what I'm trying to be in this vendor space now is kind of the golden rule vendor, right? I'm trying to be the vendor back to all of my colleagues and friends in the industry that I wish we all would have had, right? And so it's fun trying to live up to that. It's not easy, but that's what we're doing.
Right. And the thing we hear over and over again from health systems is we need to make the data actionable, and a data operating system from the presentation. I saw Imran gave me a presentation on this and a couple others. That is its purpose, is to make it actionable, to build applications on it, to be able to move it, to be able to really make it something that can be put to work to improve health and health outcomes. So
yeah.
Very well, that's the extent of what we allow for in terms of a commercial. We give everybody sort of an opportunity to talk on those things. So, our format is typically we go in the news, then we do some sound bites, then we do social media close. Instead of doing two stories and going back and forth, I wanted to take this opportunity to really delve into platforms. It's where you've lived, it's where I've lived, it's what Anish Chopra calls we're supply-siders, right? We're the people who build out the infrastructure that makes these things possible. And I'm going to use the VA situation as a muse. And it's the same intro I gave 2 weeks ago when I was talking to Ed Marks with the Cleveland Clinic. But Ed and I sort of veered towards, what you would do politically and what you would do, as a CIO to sort of, in your first couple of days at the VA. We're going to take a little different approach of, we're not going to worry about the politics. We're not going to worry about the culture. We're just going to talk about if we were building this thing from the ground up, or rebuilding it from where it's at, this is what we would do. So let me give a little background for our listeners, and then we'll jump into it. So you have the DoD, the Coast Guard, and the VA. They all have EHR stories. The patients are obviously really important. I mean, these are the people who risk their lives for us, for the freedoms that we enjoy. These are people that we would all love to serve, to just give back to them. The situation in each of these is very public, very political. So the DoD has had one of the worst EHRs as measured by surveys, and so they responded to that, and they launched a new EHR, which they call the MHS Genesis platform. It's built on Cerner Millennium product, and from what we can tell so far, it's going pretty well. I mean, from time to time you'll hear a senator come out, but we understand it's going really well. The Coast Guard has had a failed EHR implementation on Epic for whatever reason. Could be change management, whatever the cause is. They hit the reset button. They chose to latch onto the DoD project because they believe that the requirements are the same. So the VA, this is where we're at now. So the VA has Vista built on top of CPRS. They recently did a no-bid contract that was given to Cerner Millennium to replace Vista. Very public, very controversial. One more piece of information is, the VA actually was a pioneer in this data record space. People don't remember that, but
Yeah.
Back in 2008, when only 8% of systems were on had an electronic medical record, the VA was a leader, and they had stories on 60 Minutes and ABC and others that highlighted this new movement where we were going to be able to reduce medical errors and more effective treatments and higher customer sat, because the veterans were moving from location to location and the medical record was following them. So they sort of led us into this, but for whatever reason, now it's it's aged a little bit. It doesn't plug and play real well with the rest of the health. Whatever the rationale is, they decided to replace it. So let's get started on this. Again, we're gonna take the VA as a backdrop, and let's start with our thinking. So how do you think about this? What should a health system prioritize in terms of the infrastructure, both data, infrastructure, you name it, and how should they think about their EHR? Before we make any EHR decision, how should they be thinking? Should they be thinking about what things like agility, security? What things are we trying to accomplish?
Well, I mean, to me, I'd be thinking about agility and personalization. One of the concerns I've always had about EHRs is that it's a monolithic. I mean, frankly, all EHRs, Vista included, are built on pretty old technology that were never envisioned to be as agile as the modern software engineering, data engineering platforms that we have today. So they're hard to change, they're hard to modify, they're certainly hard to extend. And so that's one bias I've always had. And I think that bias is shared by a lot of folks, right? I don't think many people would argue against that. But the other thing that's always bothered me, and clinicians routinely reminded me of this in the trenches of care, is that it's too generic, right? Most EHRs tend to reflect sort of a primary care, general internal medicine kind of paradigm. And then we twist it and turn it and put baling wire and duct tape on it for specialties and other more personalized uses, including patients. And, at the same time, then the rest of the world, and I always hold up, my iPhone is on a platform. I have somewhere in the neighborhood of 150 to 160 applications on this. Some of them overlap a little bit, but no single vendor dominates the way I interact with the platform. The platform is dominated by Apple for sure, but the apps give me the freedom to choose what I want and interact as I want. And that's the paradigm of society in general that we have to drive healthcare towards. So a platform of data and infrastructure, but flexible, agile, personalized applications on top of that data.
Right. So if you're a cardiologist, if you're on a platform, a cardiologist would see one thing in primary care, not necessarily different data, but a different representation of the data based on what they're doing.
Absolutely.
What makes a platform a platform?
That's a good question. I like that. For me, in the way that I've approached the data operating system, and by the way, I'm not plugging Health Catalyst today here, friends. It makes me awkward to even pretend or fake that I'm plugging Health Catalyst. What I'm advocating today is things that I think everybody should be doing, including the traditional EHR vendors. They need to have something that looks more like this architecture that we're calling the data operating system. And so for me, if you look at the traditional technology stack that starts down at hardware, operating system, and the application layer, the thing that we've overlooked, especially in healthcare, is the data layer between the operating system and the application layer. It's still very, very difficult to work with the data layer in healthcare especially. And so you've got software engineering that has progressed on the platform of the public cloud. So Azure, I mean, what we can spin up now in the public cloud is incredible. It's been commoditized, and it's even better than commoditized. It's capabilities that, you and I never had in our data centers as CIO.
Right.
And we can spin that up in an afternoon. Well, now we've got these incredible software engineering tools and applications on top for agility that we can spin up applications in Angular and D3 at rates, 10 to 100 times faster than anything I could do earlier in my career.
Yep.
But that layer between the OS and the application is still, that data layer is still very hard to work with in healthcare. So what we need to do is build out something that looks like this data operating system, where we take advantage of the public cloud and all that great hybrid architecture that exists now between SQL and NoSQL and big data, data lake concepts. We take advantage of the software engineering tools that exist on top of it, but the platform now is the data on top of the infrastructure of the public cloud. And of course, APIs on top of that data, so that all these brilliant application developers have a much easier environment to work in. So to me, that's what a platform is. It's take advantage of the public cloud, move it up to the data layer, curate the data in healthcare, then put APIs on top of that data layer, and then the possibilities are almost limitless about the applications you can write on top of the data.
Yep. And when I'm asked that question, because I talk about platforms a lot, I talk about platforms to my clients and others, but what we talk about is the distinction of a platform is, first of all, it's intentionality. It was designed for others to build on top of it.
There you go. Yeah.
And so that's the intentionality of it. And then the other is the layers of abstraction, right? So there is a data layer, there's a business logic layer, there's a presentation layer. There's a security framework which envelops that whole thing. But all of them are accessible programmatically. So now you hand this to, well, actually you walk into any college now and you can put together a hackathon or whatever they're called today. And literally you can say, all right, here's the APIs, here's how you access this data, and build it on whatever you want. Build a web app, build a mobile app, use whatever development platform you want to develop. But because of its specific intentionality to enable an ecosystem of developers, and in the case of Amazon, it's a platform because it enables an ecosystem of businesses to resell on it. iTunes is another platform, and I just.
Salesforce is probably the classic example, right?
Yeah, exactly. And the thing we've experienced and the thing we're talking about here is the level of agility a health system is able to come up with. So you and I have both experienced this. When you have an EHR and you go, all right, we want to do this new thing in the EHR. And we did about 20 of these a year, where we sat down with the EHR provider and we said, we want this custom. We always call them customs. And we sit down, each one cost us, I don't know, $250,000 to $1 million to do, because they're complex and and it's across 16 hospitals. So it's not a simple thing. Whereas if it's built on a platform, the integrity of the data is handled by the data layer. The integrity of the business logic and you can start to split those things apart and build very personalized applications for that.
Totally.
Is any EHR provider heading in this direction that you know of?
Not that I know of, friend. I mean, there are bits and pieces, and of course, FHIR is emerging, and we can talk about FHIR later if you want to, but I just don't see it. And of course, that might sound like and we compete against EHR vendors. But I can tell you that opinion would come from me whether I was competing or not. If I were a CIO in healthcare right now, I would be really disturbed by the lack of progress that the EHR providers have made in this. But I would also say this: those platforms, the core of those platforms that dominate the market right now, started decades ago.
Right.
And I say all the time, there's a reason we don't build code in VB32 and COBOL and Fortran anymore. At some point, all tech companies have to bulldoze themselves and re-engineer, especially in the old days. I mean, nowadays you can actually evolve a little more gracefully, but I don't see any evidence that the dominant EHR vendors are bulldozing, taking all that high-tech money and all those profits. They should be bulldozing that old technology, and they should be building next-generation EHRs around modern Silicon Valley kinds of concepts. And I don't see it happening.
So I think I read an article from Jonathan Bush talked about rebuilding based on microservices and those kind of things. So let's talk about what are the core technologies if you were redesigning. So let's go back to the VA. VA has Vista, and they have a choice of going to Millennium. I think it's, by the way, I think it's an irrelevant choice.
Me too. Totally.
And if you give me $15 billion, my response would be, I'd rather stay on Vista. I'm sure operationally it does what it does, and then you can build out a platform. But what things would we, I threw out microservices and services. What kinds of things would we look for in a modern EHR that would define a technology platform that you think would work?
Well, I would say let's give the attributes of the platform, and then you can spin off whatever you want to, including an EHR from the platform, right? Once you have the data, then you've got the platform, there's like unlimited use cases with it, literally, right? And so you have to have sort of the abstract layer and the reusable content and logic, the curated data that's facilitated with APIs. That's fundamental in healthcare, so that the application doesn't have to constantly do that. So registries, core things like registries, metrics, value sets, embedded machine learning, so that it's not something that you do as an afterthought, but you can call an API and you can bind your data to a machine learning AI model without doing it externally to the application. It's a natural part of the data first application. It certainly has to support real time. It has to support batch analytics, right? Yep. It has to be microservices based. And there's a lot of debate about what does microservices really mean. We can talk about that, but what it means is continuous delivery, right? No more of remember back to the days when you had to upgrade an EHR? Yep. It was a thousands of hours initiative that took months and months to plan and execute. And even then it was painful, right? As opposed to the microservices continuous release cycle that we see now. So let me comment on that, by the way. So the data operating system we have right now is microservices based, and we're able to push out updates to our apps and the platform now faster than the cultural ability of health systems is to adapt to it. Because the culture, our IT shops are accustomed to very rigorous configuration control and release schedules. At best, it's like once a month, generally speaking. It's certainly not daily. So that's an interesting thing that's evolving. Back to the attributes of the platform. The platform has to support the integration of text, discrete, and image data. You have to be able to support that and make that a natural part of the data ecosystem. I think I mentioned real-time streaming. It has to do that. Batch analytics. By the way, if folks want to study this a little more, it's an easy study. Kappa and Lambda architectures in Silicon Valley are the role model that we should all be following. Those design patterns are what we should all be following. Yeah,
it's wow. There's so many directions to go from here. So, but I'm gonna bring it back a little bit because we just, we're plumbers, right? So we're talking really down into the weeds.
Yeah.
So let's pull it back a little bit. So we were talking about the VA. So the VA is going to stay with Vista, and Vista is going to be a core, let's call it a transactional platform, right? So it's a transactional thing, and we're going to build around it. So the first thing is, cloud DevOps, let's get that sort of stood up, and then let's keep that transactional layer there. But then there's probably another layer. So for our health systems that are watching this saying, well, this is a little bit out there, it's not really out there. What we're talking about is using the traditional, what they would think of as a traditional enterprise data warehouse, and making that into, and really enabling that platform, and then putting a set of APIs and an architecture around that can tap into machine learning, tap into AI.
Totally.
Into the cloud and those kind of things. So this is very practical for every health system that's saying, how do we get to the next level? And the EHR isn't moving, and it can't move fast enough. It's the architecture of it will not allow it to to move quickly. They almost have to do the same thing we're talking about, which is take all the data, move it out, put a new architecture on top of it, and that's what they're going to build on. So what does the traditional CIO, what does the architect of a current health system, how should they be thinking about, let's go in this direction. How should they be thinking about tapping into AI and machine learning? Everyone's talking about it, and they're saying, okay, how do I do this? Do I just move all my stuff to Azure and that's how I'm going to do it?
Well, the challenge that you have as a CIO right now is that you're, unless you're in a forward-thinking organization, the loyalty and the commitment to the EHRs is significant right now, right? You've just spent hundreds of millions, if not billions of dollars on an EHR implementation.
Yep.
And the notion of doing anything else other than that is not very appealing right now. Everybody's a little worn out by it, financially and culturally. So what I see in the market right now is the hope that the EHR vendors will evolve towards the platform and that they will provide AI and machine learning capability. I see a lot of hope about that. The other thing that I do see occasionally is a very unique niche-based AI platform being installed in an organization that extracts just EHR data out, and you might run predictive models for cardiovascular events or oncology or something like that. And then I see maybe a third tier where it's kind of a fascinating thing that's happening. There are some organizations that are saying, we recognize that the EHRs on the current trajectory are not going to meet our platform needs. So we're going to build our own, which is interesting. It's because, it's attractive because the public cloud has made building your own feel more within grasp than ever before, right? In the old days of building a data warehouse platform, that was a significant infrastructure investment, very unique skills, hard to do. Now that's been commoditized. But I also draw a parallel between that and the old white box PC, build your own PC, 20 years ago, when we all thought, why should we buy from IBM and HP when I can go buy all the bits and pieces and build my own PC for a fraction of the cost?
Right.
Nobody does that anymore, right? And that's the same thing that's going to happen. It feels like you can build your own platform now and sustain it, but the reality is it's a fool's errand because you can't. The platform's been commoditized. The data is the important part, and the curation and the management of the data and the logic is the hard part to scale. I have this theory that in probably 3 to 5 years, I think the dissatisfaction with the current EHRs will reach a pain point at which the market demands something else, and an alternative will start to emerge. And the loyalty to those current EHR vendors is going to be diluted. And I think we're going to see a bit of a renaissance. I think the second phase of healthcare IT renaissance, the real phase, is going to happen in about 3 to 5 years. That's my theory.
Yeah, I have a similar theory, and this will actually be a segue. So my theory is that CMS continues to step up their game in terms of interoperability.
Yeah.
Moving that data around. Once we are able to, I have this mantra: free the data, share the data, apply the data. And I think that's what leads to transformation within healthcare. And if they continue to push, and CMS is Medicare, and Medicare is the largest payer, and EHR providers are sort of forced into this, opening up that data set and moving it out, I think you're going to see, in probably that same time frame, 3 to 5 years, really an emergence, a renaissance really around the experience, around outcomes, because these innovators have been sitting on the sidelines saying, I can't get the data. And they go to these various ways of getting it. And then the other thing is it's really expensive to get it. So FHIR becomes the other way that you can get it without paying the exorbitant cost. So where do you think we're at on the FHIR life cycle? Obviously, it's an important step in interoperability, and it's a huge undertaking. What's the maturity level of the FHIR API? What's in terms of working with it? What are you finding?
We like it. I've been notoriously critical of HL7,
Yeah.
message-oriented architectures. They're so fragile, outdated, as from your background, ignoring services-oriented architectures. So the fact that Fire kind of emerged out of the rebels in HL7 has been awesome, and it's a very solid approach to this problem, and we embrace it. We like it. It's not moving as quickly, of course, as we'd like it to, because it is consortium based, but it's moving fast enough. The EHR vendors are now starting to catch on a little bit. The leading EHR vendors for a long time were dragging their feet, because I had a conversation like this back at Northwestern. I approached one of those leading EHR vendors with concepts around services-oriented architectures and APIs. And I described the concept to this leader of that EHR company. And their response, I will never forget. They said, well, Dale, that's very interesting, but we see ourselves as more than a database vendor. And so what their mindset was, if we open our APIs, we diminish the value of our product, which is completely opposite of reality. So those cultures have changed some. Now we see, the application, the app stores, coming out of all the leading EHR vendors, and there's some progress being made. But the reality is, and I did this in the old days, you can't wrap modern APIs around old architectures and expect a miracle.
Right.
That's the bottom line. We did this at Intermountain, right? When we had help, all written on Tandem system and Tackle and, very proprietary languages. And we wrote Java-based APIs around that environment. And so that writing those Java-based APIs around that environment was interesting and kind of helpful, but it didn't do what we needed it to do, and it didn't survive. So you can't just write web services and APIs around old architecture and expect it to be the miracle that people expect.
Yeah. Oh, that's interesting. I'd love to go on in this conversation, but it is a 30-minute podcast. So I'm going to jump to, and actually we really could talk about this for
yeah, it would be fun.
It really would be. We're going to move to our soundbite section. I have 5 questions. It's just rapid fire. I ask the question, 2-minute answer on your side. And I know that some of these questions are pretty big, so, give it your best shot. So
okay. All right, here we go.
First question. How will precision medicine change healthcare in the next 3 to 5 years?
Probably, if I had to guess, in pharmacogenetics mostly. Every time I have a lot of faith in genetic precision medicine, and I think precision medicine, I'm always thinking about genetics, but then along comes epigenetics and the microbiome, and we think we understand things, and suddenly we don't. So I think probably pharmacogenetics is the most likely place that it will be high impact.
Yeah, I went down the human longevity, had my genome mapped, and they came back with a report, and they said, hey, these medications will work for you, these won't work for you, kind of thing. And I thought, yeah, that's the future. That's what it looks like. It's very specific, dosages and medication based on our makeup. Question number 2, what do you think innovation in patient engagement is going to look like?
Well, I think we're going to knock the expectations down about patient engagement. We're already starting to see that in the industry, where there's probably 2/3 of patients that don't really want to be engaged.
That is true.
Now, that's the reality, right?
Yeah, that's
and
true.
I'm kind of one of them. Don't bother me, really. Don't engage me. I'm okay. Just kind of leave me alone.
Yeah. Don't call me. I'll call you.
Yeah, but when I have a condition, when I want to be treated, let's make it safe. Let's make it efficient. Let's make it personalized. So I think we need to shift this notion that we've got to constantly engage with patients and expect them to engage. Some folks don't want to be engaged. Some folks can't engage for various reasons. And we just need to refocus and say, let's provide really good, personalized, safe, efficient care.
I love that answer. That's really interesting. I'd not taken that tack before. I will put that in my. I'll file that away. What's the biggest barrier to innovation in healthcare today?
Well, 2 things.
Don't get yourself in trouble. So just
I'm not good at that, actually. Getting myself in trouble is what I excel at. It's certainly the economic environment. The behavioral economics of healthcare are a mess. The administrative overhead is a mess. That whole, because we have so much administrative inefficiencies and so many rent seeker economic layers, the resources we could use for innovation are constantly on the treadmill of overhead.
Right.
So we've got to drive towards more efficient economic models. We've got to disintermediate those inefficient layers in the economic environment to free up money and time for innovation. That's one thing. Reduce the number of measures, right? We have to stop over measuring clinicians. That's one thing that's, that's not the fault of the EHRs. It makes them so unusable. We're over measuring clinicians, and we need to stop that. It's disheartening to them. But then the other thing that's holding innovation back, frankly, is the software. All other industries are differentiating themselves through software, and we can't do it in healthcare.
I will agree. What will it take for machine learning AI to take hold within healthcare?
Well, it's starting to take hold, but here's the thing that is a little bit of a fallacy. AI and machine learning require breadth and depth of data, right? My background includes time with NSA, pioneers in AI and machine learning, unlimited budgets. And what I learned then is that you can't just have rows of data. You need to have lots of facts about those rows of data as breadth and depth. If you think about it in healthcare, on average, we only see a physician or a hospital 3 times per year. That's equivalent to our digital sampling rate. We have a very, very thin digital sample about us as patients that the healthcare system sees. So when we talk about big data in healthcare, we're not big data. We collect 100 megabytes of data per year per patient. That's nothing. Yep. So AI and machine learning will never be fully realized in healthcare until we round out the full digitization of the patient, and we shift the focus of data from the limited data set we have in the EHR to a patient that's fully censored and collecting data on a 7x24 basis of some kind. So we're doing some cool things and interesting things with AI and healthcare with the data that we have. But the reality is you can't believe the results too much because the data is so thin. You have to be very careful about believing AI and machine learning in healthcare right now because the data is so thin.
That's interesting. Our experience was that the machines at the bedside provided the best opportunity as a place to start in monitoring and analyzing that data and predicting events before they were going to happen because you were getting that steady stream of data.
Stream, right? Yeah.
Yeah.
It's what I call instrumentation of the payload, which comes from my satellite days in the Air Force. It's instrumentation of the patient.
Yep.
Yeah.
You're huge into EDW. What's the future of the EDW within healthcare?
Well, old school batch-oriented, read-only data warehouses are already outdated. So if you have one of those, you got to figure out how to get off of it. It's what it amounts to is that it has to be a platform that looks like these Lambda and Kappa architectures, which is a single stream of data feeding both workflow and batch analytics. And you can run real-time applications and analytics off of that platform. But old school batch-oriented EDWs are over.
Wow. Well, yeah. So I know this half hour goes really fast. Let's close out with social media posts. I usually try to close out with something funny. This week I don't have something funny. I just something that I find interesting. David Miller, Chief Executive Officer for Cios Consulting, shared a Gartner study that said only 1% of CIOs are adopting blockchain for the enterprise. I have theories as to why that is, but that number does not surprise me all that much.
Yeah, me either. It's overhyped like Hadoop was, 10 years ago. It's interesting. I mean, we've looked into it very deeply, and it's fascinating. Somebody asked me the other day, shouldn't we be doing more in blockchain? And my response was, it's almost too disruptive.
Yeah.
It's almost too disruptive. I mean, technically it has some challenges. It won't work quite as well as people think it will in healthcare, but it's almost too disruptive to adopt in healthcare right now. I think it will be pretty important maybe 5 to 8 years from now.
Yeah, I only have one client who has me working with them on it. And essentially what I'm saying is it feels like 5 years out, and
Yeah.
there's so many obstacles, but I don't want to go down that path. So what's your post for the week?
My favorite post of the week it's actually a Harvard Business Review case study that came out of the University of Utah, right down the street here in Salt Lake City. And in that, the summary of that story was their use of cost data and outcomes data to truly understand the healthcare value equation. So if the healthcare value equation is quality of care over cost of care, right? That's the value equation.
Yep.
Quality of care over cost of care. UofU's done a pretty good job with their own cost accounting system. And in particular, in surgery, they've done very well. So they know their costs quite precisely in the surgical area of the UofU. But what they've also done is very formally measured outcomes associated with the patients and everything that contributed to that particular outcome. So now they bring all their surgeons together with that analytics, and they can explore the health value equation for, both individual patients as well as aggregates of patients. So that's where where we need to go with all forms of decision support in healthcare, right, friend? It's what I call the outcome or cost per unit of outcome achieved.
Yep.
And we got to get away from readmissions as a proxy for outcome, right? It has to be based on promise and promise 16 and functional status and that kind of thing.
Yeah, and that's the to enlist physicians in reducing costs, show them the cost article in the Harvard Business Review. And that's interesting. I think we always assume that people want the highest quality of care regardless of cost, and that's just not the case.
Right.
And more and more as we become consumers of healthcare, quality of life, mental health. I mean, there's so many things that go into it. Yep. I don't want to spend all my money on healthcare, anyway, right. Regardless.
Right. Yeah. So that article goes into the details. I highly recommend everybody read that article. That's in general what we need to propagate in all areas beyond surgery.
Well, that's awesome. Hey, thanks for coming on the show. How can people follow you? Do you have a Twitter handle? Do you out on LinkedIn?
Yeah, I'm sort of up and down, on that kind of thing, but I'm on, my Twitter handle is Dr. Sanders. Everybody thinks that's Dr. Sanders. That's just my middle initial, Dr. Sanders. And then I'm on LinkedIn too, and I post out there every once in a while.
Dr. Does that get you in trouble from time to time?
Well, that doesn't really, as long as I don't practice medicine, it keeps me safe, but I have to explain to people a lot of times I'm not a doc.
That's funny. Awesome. So you can follow me on Twitter at the Patient CIO, my writing on the Health Lyrics website, and I have a new article out on Health System CIO this morning on data brokers and the disintermediation of data brokers due to the CMS proposed rule. We'll see where that goes. Don't forget to follow the show at This Week in HIT and check out the new website, thisweekinhealthit.com. And if you like the show, please take a few seconds and give us a review on iTunes and Google Play. And as always, we are now up over 100 videos on our YouTube channel, thisweekinhealthit.com/video. You can check those out. And please come back every Friday for more news, commentary, and information from industry influencer. That's all for now.
Thanks, Bill. Good job. Good on you for doing these.
Thanks. I appreciate it.